You're all invited to this event. Please join. And so we're going on with Professor Yousem. Thank you so much.
Thank you, everybody. So this is a little bit more laid back. I'm going to talk to you about some of the research that I've done on imaging of the olfactory system. The olfactory system, after having lunch, and since I have mostly French people in the audience, you know that the taste of food and wine, if you hold your nose, very bad. So imaging of olfaction is very, very important. And for Catherine, je voudrais parler en français un peu. S'il vous plaît. This work was sponsored by the National Institutes of Health. I have to tell you that as part of my application for the grant for imaging of the olfaction, I did include a picture of my qualifications, and I think that really helped with getting the funding to do this work. So for once, the Jewish nose did help. So as I said, the olfactory system is very important, and it helps with regard to smell and taste. I'm going to talk to you a little bit about aging effects. And when you hear about, for example, the elderly being trapped in their homes with carbon monoxide poisoning, and they didn't realize it, in part it's because of that diminution in the sense of smell with age. Obviously there are some professionals that rely very much on their nose, the chefs, the wine tasters, and there are also important implications with regard to memories. When I smell Chanel No. 5, I think of Maury Cummins, my 11th grade girlfriend. It's just a very vivid memory, and the two are often related, smell and memory. So what's known is that the olfactory nerves, the primary sensory organ is not the olfactory bulb and tract. It's those nasociliary nerves that perforate the cribriform plate and then make their first synapse on the olfactory bulb, and then the olfactory bulb goes back to the olfactory tract and then infiltrates basically much of the limbic system and the hippocampus. There are a lot of different causes of diminution in the sense of smell. As I said, age is number one. That happens naturally. But we all know that we get a viral illness, an upper respiratory tract infection, and suddenly you can't smell things, everything tastes very bland. In some patients, that never comes back. They have about, a permanent damage to the olfactory system, and they never are able to smell things the same way thereafter. Trauma is a big cause, usually due to the shearing injuries that may occur at the skull base, and I'll talk a little bit about that. And then there are everything else about idiopathic toxic medications that may do that. Now this is a very important graph that I want to point out to you. This is the scores on the University of Pennsylvania smell identification test. It's a forced choice, 4 multiple choice questions. You scratch a smell, you sniff it, and you have to identify what that odor is. You scratch it, you sniff it, you say, that's lemon. You have 4 choice, it's multiple choice. If you randomly just guessed, you would get about 10 right, 1 out of 4. And so when we talk about anosmia, we usually are saying those people that are down here at an upset score around 16 or less. You have microsmia, very little sense of smell, about 24 or less. You have hyposmia, 24 to about 32. And then you have the normosmia, which is about 36. What I want to point out is the 2 different colors here. So the solid round line are the women. The boxes that are open are the males. And you notice that at every single age group, women smell better than men in more ways than one. Okay? Their sense of smell is better, and not only that, but their ability to detect an odor is much better. So the odor threshold, women much better than men. So that's why women, when your boyfriend or your husband can't smell the dirty rotten trash or the dirty rotten underwear, it's because we're down here, you know? But you also see that with age, the sense of smell deteriorates rapidly at the age of about 60. And I'm going to get back to that because that's very important. So what I did as part of my research was we looked at the volume of the olfactory bulbs and tracts in different disease entities by doing surface coil imaging, 5-inch round surface coil placed on the nasion, and then doing coronal scans sequentially. So you saw the olfactory bulbs pretty well. This is the olfactory sulcus, the gyrus rectus. You continue backwards, you start seeing the junction between the olfactory bulbs and the tracts. Here you're seeing the olfactory tract just below the olfactory sulcus here, again gyrus rectus, and you can follow these back sequentially until you get into the olfactory stria and the mediolateral bodies. So what we did was we were circling the anatomy here sequentially over lots and lots of different diseases until we got back, and here you see it entering into the perforating substance here of the brain. So from that, we were able to get three-dimensional volumetric images, and from that, we were able to measure the volume. Now, as I said, there's lots and lots of different causes of decrease in the sense of smell. Most commonly, besides age, sinusitis. In this case, the patient had allergic fungal sinusitis, but also post-trauma. And what we saw post-trauma were all those patients that you see that have injuries in the inferior medial frontal lobes along the gyrus rectus. Many of those patients have lost their sense of smell. And our concern was, is that due to injury to the olfactory bulbs and tracts, or was that due to the ciliary nerves going through, or was that due to temporal lobe abnormalities, which also may occur in trauma? And so we looked at that as well. And then we have those patients who don't have any olfactory bulbs and tracts. These are the patients with congenital anosmia. We hear, the one that most people know about is Kallmann syndrome. But you can also see that, in addition, in holoprosencephaly, also known as a rhinencephaly. The rhine here is because of the absence of the olfactory bulbs and tract. Here's another example of Kallmann syndrome. We often saw absence of the olfactory sulcus with the absence of the olfactory bulbs and tracts, well recognized on high-resolution imaging. So let's talk a little bit about the various factors. When we looked at those patients with trauma, we largely saw a diminution in the size of the olfactory bulbs and tracts in 80% of the cases, but there were some patients who had normal olfactory bulbs and tracts that we believe were due to the shearing effect at the cribriform plate of the nerves getting up to the olfactory bulbs and tracts. We looked at the congenital anosmic patients. These patients are fascinating because in first grade in America, they do a subject which is the 5 senses. And these kids repeatedly come home to their moms and pops and say, I failed smell. Up until that time, they didn't know they didn't have a sense of smell. It doesn't come up. But when they are asked to do it in school, that's when you realize that they have congenital anosmia. They get imaged, no bulbs or tracts. Very fascinating. One thing I want to say, just for those people who do some clinical work out there, when I was an intern, the way we used to test the sense of smell was we would take an alcohol swab and we would wipe it underneath the patient's nose and say, can you smell this? Alcohol is a 5th nerve stimulant. It has no olfactory nerve stimulation whatsoever, so you shouldn't be using alcohol to test the sense of smell. You have to do something like phenylethyl alcohol, which is rose oil. So we looked at, among other things, patients who have neurodegenerative disorders, because what's fascinating is that Alzheimer's disease patients, before they note memory loss, lose their sense of smell. The reason why I showed you that normal curve is because it's difficult, because the natural sense of smell is declining over time. But when you look at the patients with Alzheimer's, they're way 2 standard deviations beyond that normal decline in the sense of smell. But no one tests them. They test their memory, they test their cognition. No one's testing their sense of smell. And when you look at their patients, for example, Parkinson's disease, same thing. They lose their sense of smell. They lose volume in the olfactory bulbs and tracts. The Alzheimer's patients, as you see, don't lose it. They lose it by virtue of that temporal lobe, hippocampal, entorhinal cortex abnormality. What is also fascinating is that if you do sampling of the olfactory bulbs and tracts, you see predominance of neurofibrillary tangles in the olfactory bulbs and tracts in patients with Alzheimer's. There's amyloid deposition that's occurring there. So here, for example, are the control population. We're looking at both the UPSID test, that's that 40-item forced choice question, with the normals, and here you have the normal controls, and here you have the Alzheimer's disease, and you can see the median values are quite different. The Alzheimer's disease patients down here at 18, which was what we would call microsmia. And notice also that the threshold at which they detect an odor, as you increase the concentration of the odor, is much higher in those patients with Alzheimer's disease rather than the controls. Now, people have finally gotten around to figuring this out because of a guy named Dick Doty, who is the head of the University of Pennsylvania Smell and Taste Center. And he keeps saying, you gotta test olfaction, you gotta test olfaction. So finally, this is from the lay press in July 2014, the UPSIT, odor identification testing, could be an affordable and quick screening of Alzheimer's disease. Now the UPSIT test costs about 60 cents to do it. How much does a MR PET cost? What do you want to do if you want to have economic imaging? The second study found that among 757 participants, lower scores on the UPSIT smell test for 60 cents were associated with transition to dementia and Alzheimer's disease. So testing the sense of smell, even clinically with something as much as a little scratch and sniff test, is very useful. However, we can get into fancy radiology stuff. And the fancy radiology stuff that we do at Johns Hopkins is done by a guy actually on the undergraduate campus by the name of Mike Miller. He's very a volumetry guy, and he looks at the different parts of the hippocampus because hippocampus is kind of non-specific. What part of the hippocampus or the adjacent structures is most likely to predict whether or not a patient is going to progress to Alzheimer's disease? So he looks at the Nterminal Cortex, the amygdala, and the hippocampus itself, and then he does looks at patients who have mild cognitive impairment who progress to Alzheimer's versus don't progress to Alzheimer's. And he does very fancy, as you see, these color coding of the different anatomy. And what he has shown is that the entorhinal cortex is the structure that can separate those controls from the patients who become symptomatic with Alzheimer's disease, and even those that are preclinical, that just have minimal memory impairment. You notice that there's a big difference in the entorhinal cortex volume and surface area between the controls and those patients. So, entorhinal cortex, rhinal, right? Smell. So it's all coming around. So what I tried to do was to do analyses of the sense of smell in the magnet by doing olfactory stimulated functional MRI. So I started out my research, and I had this $250,000 olfactometer that Dr. Doty had purchased, and we would blow odors into patients' nose. And we did a simple paradigm box design where it was 30 seconds on, 30 seconds off, 30 seconds on, 30 seconds on. And we were using a pure olfactory stimulant, which was phenylethyl alcohol, which is rosewood. And I did 15 patients, subjects, with the NIH's money, and I had absolutely no activation whatsoever. And I scratched my head and said, what am I doing wrong here? So how many of you wear cologne or perfume in the morning? How long does it take before you no longer smell that perfume that you put on in the morning? 5 seconds, right? You squirt it, you smell it, then it's gone. Well, that was what was happening with me. I had 30 seconds on, 30 seconds off, but in that 30 seconds of stimulation, they were only stimulated about 5 seconds, and then they habituate. So I went to my guru of functional MRI, Dave Alsop. I said, I don't understand, I'm not getting any activation. You know, he said, Dave, when we do visual stimulation, we don't just shine a light in the patient's eyes for 30 seconds. We blink it. You know, you have the flashing lights. You need to flash odors. So, went back to the drawing board, and then I had every 5 seconds a different odor. So there was rose oil, there was hydrogen sulfide, which is rotten egg smell. There was wintergreen, eugenol. We had all these different odors that I would vary to try to keep the patient stimulated. Didn't do too well until I figured out that I have to tell them when to smell. Because some of them were just holding their breath, you know, they weren't. So then I gave them a little visual stimulation and said, sniff, 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 every 5 seconds. So they would get a new odor every 5 seconds, and voila. You see it? We got stimulation, so it was very nice. So when I looked at this, I said, all right, well, let's just start out doing just men versus women, left and right, see what we got. And what we found was that in the women, there was much more activation of the important areas than there was in men. And we counted voxels in the inferior frontal and the inferior medial temporal lobes, etc. Women activated much more of their brain than men. And so then we had this big, sort of scratching our head. Does it take more brain for women to smell well? Is that what's going on? That they're stimulating, because who knows? So we had this debate between the women and the men in the room, and we decided that women smell better than men. Oops. Then we looked at the young and the old, and again, we're on our way to trying to figure out Alzheimer's disease, so we had to have old controls and young controls, and as you see, the old did not activate as much brain as the young did in the important structures for functional MRI, and those being the medial temporal lobe areas and the inferior frontal areas. And we documented that with the number of voxels. And this has been reproduced by other researchers, Claire Murphy being one person over at UCLA. And this is the young people above and the old people below. And as you can see, there is decrease in the amount of brain that's stimulated in the young people, which correlated with the opposite scores. So we're going on the right track. The problem is that there is a diminution in that activation over time. One thing that's interesting, I saw this article in 2013 looking at neonatal olfactory stimulated fMRI, and they were using different types of milk, sour milk and non-sour milk as their stimulant, and they were showing that there was activation in the neonatal brain. And again, what's nice about olfaction is patients don't have to really pay attention other than they have to be able to sniff and smell. And so even in the neonate, you see activation of the medial temporal lobe when they're having olfactory stimulated fMRI. And this then, the next thing I see is these people marketing their Similac and their different breast milk that they stimulate more brain than the competitor milk product. See, commercialization in America, right? It's capitalism. So, unfortunately, while I was doing this work on the East Coast, there was this really bright Israeli guy named Noam Sobel who was doing it on the West Coast. And Noam said, maybe it's not, what you're seeing is not olfactory stimulation. Maybe you're seeing sniffing stimulation. In other words, maybe the act of sniffing is causing your activation, Dave, rather than the odor itself, because you're telling them to sniff. What if he's right? So, Noam had olfactory fMRI studies where he was just telling them to sniff without any odors, and just the motor activity of olfaction, if you will. And sure enough, lots of activation, right? So he started to do this study about, all right, well, let's do smelling without sniffing, sniffing without smelling. It got really muddied at this point. And I will tell you that there is a component of just the active sniffing, the motor active sniffing, that will stimulate portions of your entorhinal cortex. Not all of it, because even without sniffing, if you're doing passive, and he would blow the odor, he had a device that would blow the odors in without having the person actually sniff. And he did show that there is odor activation as well as sniffing activation. But he was a real smart Israeli guy that just got me, So then I said, well, yeah, you're going to talk about sniffing. What about the left nostril versus the right nostril? Is there nostrilness? Because we have handedness. Do we have nostrilness? So I said, you're going to do the sniffing. We're going to do unilateral sniffing versus bilateral sniffing. And so I one-upped him and showed that, nostrilness does matter in the different temporal lobes in which one is activated. So as you see, the right on this side, and if I go backwards, the left on that side, and the medial temporal lobe. So back and forth, East Coast, West Coast, Israeli, and Jewish American. So the next thing that he started to talk about was blind smelling. So he would he would try to suppress the actual smell. So he would pump the odor in and, under the sniffing, but tell the patients not to perceive the odor. You can have the airflow with the odorant, but not perceive the odors. This is what he called blind smelling. Oh my God, it's like it's up in your bar here. And sure enough, you can have different areas of activation with blind smell without the perception of the odor. So this was blowing it without perceiving the odor. And you can do this pretty easily because I had a whole group of congenital anosmics. So they can't smell at all. So I can blow stuff up their nose and the odorant and have no perception. So I did in my paper one blind smell with anosmics. One for the American. So then Noam started to do stuff with odors. And this is really important because I was using some pleasant odors, and then I had my rotten egg odor. So he said, well, how much of this activation is a component of the hedonics, the pleasantness of the odor? And so he started looking at unpleasant versus pleasant odors, and as you can see, showed different parts of the brain that could be activated with the pleasant versus unpleasant. And then he started looking at just imagining odors, pleasant and unpleasant. Just think of that rotten egg in the bottom of your sink that's been there for 5 days. Think of those unpleasant odors versus think about Chanel No. 5 and Maury Cummings, Lemon Cream. And so you can see that there's differential activation that is also related to sniff duration. So this is, again, part of his work in looking at the different areas of the brain, what relates to hedonics and what didn't, and suffice it to say there was more right with regard to the pleasantness or unpleasantness of the odor. So with regard to this work, so the question is, do I need my $250,000 olfactometer to do this work? Or can I just tell the patients to imagine an odor? So this is just some of the work doing, just telling the person on, off, imagine this odor, imagine this odor, imagine every 5 seconds you're telling them to imagine an odor and seeing whether you can get the same level of activation as if you actually gave them the odor. And suffice it to say, you do, just like with visual stimulation, you do get some activation, not to the same level as actually giving them the odorants. So the results of what I was doing showed that women had more activation than men, young had more activation than the old. Right and left, you do have handedness or nostrilness, if you will. And then there were some elements of hedonics that were related to the temporal lobe. And then, again, you can't use anything that has trigeminal. That stimulates everything. So with all these different variables and how people respond to different odors, it got very complicated in deciding how to create the different protocols. And the other thing was the habituation process. Now, I didn't do this work, but there were papers written on the first time you smell the odor versus the second and third time you smell the odor. And you could see that even this was like at 15 seconds, you looked at the first 15 seconds of the paradigm versus the second 15 seconds of the on paradigm. And you can see that the first 15 seconds you're getting pretty good activation. In the second 15 seconds, if you're just not pulsating different odors, the patient habituates and you don't get any activation. So this was proof that that occurred. And this is my analogy that this is essentially like having your perfume in the morning. So a couple other things. Personally significant odors. So these are memories that you have about specific odors, be it car oil or burning things or your mother's chicken soup, whatever it might be. When you look at the different components of memory and odors, you can see that the subjective experience of the emotional potency of an odor-evoked memory can be correlated with specific activation in the amygdala. So again, it got a little bit more complicated because I had to find odors that people didn't associate with certain memories in their childhood or otherwise. So my goal here, way back when, before all this got very complicated, was to try to separate those patients who had mild cognitive impairment that were going to progress to Alzheimer's disease by looking at how they responded to odor-stimulated fMRI as compared to age-matched controls. That's the holy grail for me. So Next thing I did was I took 6 Alzheimer's patients and I did a group analysis of olfactory stimulation with patients with Alzheimer's disease. And to my chagrin, is that French? Chagrin? Chagrin? To my chagrin, no activation. I was like, oh no, what am I going to do? I got an Alzheimer's patient with no activation. So I went to Dr. Doty, I said, I think we're at a standstill, we got no activation. He said, well, you know, their upset scores show that they're anosmia. So what did you expect? You're not going to get any activation. I said, okay. At that point, I threw my hands up and said, it's no one's job from here on in. So there have been some articles that have been written about differentiating functional MRI maps between controls versus the Alzheimer's disease, and we do those subtraction methods. What you find is that there is a greater activation that occurs in patients who are controls versus Alzheimer's disease versus those who have mild cognitive impairment. So the bottom line on imaging of the olfaction after this part of my career in olfactory analysis is that the sense of smell has been ignored for many years, both clinically as well as within the radiology community, but it impacts across very many diseases. We wrote a paper about multiple sclerosis and olfactory values, showing that the greater, as one would expect, the greater the temporal lobe volume of plaque disease, the greater the impact on the sense of smell. Exploring functional studies of olfaction may be a worthwhile endeavor, particularly for the analysis of patients with neurodegenerative disorders, and in particular those patients who have mild cognitive impairment, but there are a lot of variables. And the final thing I will say is that my research stinks. So I want to thank you all for your attention for this little lighthearted view of research.